The scientific agenda for the 2025 NEI Spring Congress will cover everything from traditional medications to what's new on the market now, filling any gaps in your education as well as new developments. Register now for our popular spring event being held May 8th through the 10th in person in the city of brotherly love, Philadelphia, which is also the city where I was born and raised, my beloved hometown, and via simulcast online. Secure your spot today at nei.global/SP Congress 25A. That is nei.global/SP Congress 25A.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, your host. And with us today is Dr. Carla Sharp. And Dr. Sharp is at the University of Houston and specializes in a variety of disorders, but including borderline personality disorder. And she was involved in the recent American Psychiatric Association's updated practice guideline for the treatment of patients with borderline personality disorder. Carla, how are you?
I'm doing very well, thank you, Andy. How are you?
I'm great, thanks. Well, I'm really excited to talk about this because, to be honest, we don't get enough education on this condition, which of course is a big clinical challenge. I specialize, of course, in psychopharmacology medications, and we don't have a lot of approved medication. We don't have any medication approved, and very few evidence-based treatments. We have some evidence-based psychological treatments, of course, but this has been the Holy Grail. There have been a couple of trials with medications that have not been successful, and part of it might be the difficulty of studying this population. But why don't we start out with let's start out with big picture. Borderline personality disorder, what it is clinically, how does it look, and how can we make the assessment a little more accurately and quickly? Because I've seen a lot of people throw out the term borderline for a patient they just don't like or something.
Right, yeah, it is unfortunately one of the most stigmatized mental disorders out there. And so thank you so much for the opportunity to discuss this disorder with you. And I hope that we can destigmatize it a little bit too. Yes. Through the conversation that we're having today by demystifying it a little bit. So to recognize BPD, I think we are in a bit of a transition period that I want to alert the audience to. We have two parallel systems for diagnosing personality disorder in the DSM-5 right now. In Section 2 of the DSM-5, we have BPD as we know it, as a categorically defined personality disorder. And there are 9 criteria: affective instability, anger, self-harm and suicide ideation, abandonment fears, relationship problems, impulsivity, emptiness, and identity problems. So these are the sort of traditional way of understanding BPD. However, yes. If you page forward in your DSM-5 to the alternative model for personality disorder, you will see the new cutting-edge way of identifying personality disorder, including BPD. And the way we do it within the alternative model is to really just shift our focus from those 9 traits to the core of personality disorder, which is maladaptive self and interpersonal functioning. Okay. So if I'm asked today, how do I identify someone with BPD in clinical practice? I would say I'm first and foremost going to look for whether the person that I'm busy talking to show evidence of problems in managing themselves in the context of their most important relationships. So if I have a person in front of me saying that I am here for help because I really struggle to know who I am as a person, I tend to morph into different types of people depending on who I am, I can't seem to have stability in my personhood, and it causes trouble in my relationships. I don't get on with people. I have really impulsive behaviors within my relationships. Then I'm going to start thinking about personality disorder and borderline personality disorder in particular. BPD's flavor compared to some of the other personality disorders may be characterized as a little bit more dramatic, erratic, impulsive, but really at its core, it is problems in holding on to a sense of self in the context of the serve and return relationships with other people. So that's what I would really look for as a distinguishing feature for BPD and other personality disorders.
That's incredibly helpful. And I was personally not aware of this updated conceptualization. The first traditional way is how I was trained about this. So thank you very much.
Yeah.
I have to back up and ask you another question. DSM-4, of course, had a multiaxial system, and the personality disorders were axis 2, and we sometimes use that term pejoratively. This is an axis 2 patient. But DSM-5 did away with the multiaxial system, and I actually found the multiaxial system pretty helpful. What are your thoughts on no longer having an axis 2 as a separate from axis 1, let's say, because you can have both?
There are pros and cons. And cons. I think one of the advantages of moving it together with all the other clinical syndromes is that it acknowledges that personality disorder is not special. So I think in the past, there were two misconceptions about personality disorder. The one was that it is a sort of unchanging part of who we are, and it's not something that's receptive to treatment, and that it's part of our personalities, our traits. And what we've learned in the last 10 to 15 years is that actually personality disorder comes and goes in a syndrome-like fashion, in the same way that depression and anxiety comes and goes. And so, people with personality disorder, people with BPD can have some days and periods where they're more borderline than other times. And so there's much more intrapersonal variation than what we previously thought. So that was one of the big discoveries. And then, of course, the big discovery of the last 20 years is that this is a highly treatable disorder. So it is as treatable with the same effect sizes as depression, anxiety, and so forth. So it's not this intractable disease that we thought about that has these developmental origins that are unchangeable. We've become much more aware of the malleable treatment targets of personality disorder that responds positively to treatment. And that's, in that sense, it's good that it moved onto the same playing field as the rest of the clinical syndromes, because it actually functions very, very similar. It's just that the pathology is not located in the mood system or in the stress system. It's really located in what the research domain criteria, RDoC, would call systems for social processes. So self and interpersonal functioning. That's where it's located. If we wanted to think about biologically as well, where is it located? And what the challenges are for psychopharmacology, then, that's, so I like that piece of it. The piece that I think, is where it was helpful to have it on axis 2 is that because it is personality functioning is a sort of overarching frame for all psychopathology. Whether we have depression, anxiety, substance use problems, all of us have a personality. And so the fact that it was an axis 2 signaled that there is a slight difference too, that what we are talking about is something that cuts across. It's actually transdiagnostic. It cuts across all different diagnoses because all of us have a personality and our personality functions a particular way, regardless of whether we have other forms of psychopathology. So in that sense, I found it helpful, but ultimately it's probably a good thing that we did away with it.
Well, that, again, very helpful. And you're bringing me up to speed here because I am steeped in 20-year-old, I guess, way of thinking about this.
Clinicians are, Andy. So I'm so grateful you're shining a light on this. Thank you.
Yeah, me too. You just said something that's really fascinating to me, and that is certainly I totally get and I agree with the idea of moving personality disorders onto the playing field. I like how you said that, or onto the same level. I wonder if we shouldn't have access to for personality style, not disorders. That would provide more color and help, much in the way we talk about coping styles, coping mechanisms.
That's a very interesting idea. And I think, the way we manage personality style in the alternative model for personality disorder is to say that personality functioning is the first criterion for diagnosis. Where does a person lie in terms of their maladaptive self and interpersonal functioning? And this can be rated from 0, healthy functioning, to 4, which is the 5th level, unhealthy functioning. And then we think about personality style, which in the alternative model is this antagonistic flavor? Is this a disinhibited flavor? Is this a negative affectivity flavor? Which maps onto the old 10 categories. So, could we think about personality disorder, personality functioning on a sort of old axis 1, and then style and flavor on axis 2? Could be, could be. I think what is interesting is that if you look at the flavor of personality functioning, all of us lie on that same continuum. So in a way, the alternative model helps us destigmatize personality disorder by saying we all go in and out of how well we get on with people. I have good days and bad days about how solid my identity feels, my sense of self, my relationships. So we all move up and down that continuum. We all move up and down a continuum of emotionality depending on what's going on with us. So I do think the alternative model helps by making it a dimension, bringing it onto the same continuum for all human beings. We're able to say, and we're all able to work on our personality functioning. We're all able to say, I'm going to be a little bit better at controlling my feelings and not being mean and, getting angry and so forth. So yeah, intriguing thought to put style on axis 2. There's always a lot of interesting and lively discussion about what to do with personality and personality disorder.
Well, I'm not a Freudian, but I do quote Freud in the sense that this continuum idea, because people ask me all the time, when do you make a diagnosis? When do you pathologize? Because it is a tough call because there is this continuum. And Freud would say to be mentally healthy is to be able to work and to love. And of course, he didn't mean work for money. It's productivity, and love is relationships in general. And I think that's really it, isn't it?
Oh, I love that you made that connection. That is the exact connection for personality functioning to make. We quote Freud now all the time because in this exact same thing, it's all about how do I get on with people? How do I get ahead? How am I productive? And that's what personality is. It's the core of personality, and it's some people get stuck with that. Some people need support and help with getting on with people and getting ahead, having self-directedness, having a sense of self, and so forth.
Well, I'm going to ask you to bring me up to speed to the modern era on another conceptualization, which was the old cluster. Yes. Cluster A, cluster B, cluster C. I kind of found that helpful, but what's the modern thinking about that?
I found it helpful too, because I think there are these flavors. There are people with maladaptive self and interpersonal functioning who are just more withdrawn. Then there are people who are eccentric and quirky in their presentation. And then there are dramatic and erratic presentations. So that was the A, B, and C. So I did find it helpful. However, the data is clear that when we factor analyze the 10 categories, we don't find those 3 clusters come out that neatly. What we do find when we factor analyze is 5 trait domains. And that's what's now in the alternative model. So we have negative affectivity, which is kind of neuroticism, really. We have detachment, which is this withdrawn. We have disinhibition, which is this sort of extroversion. We have psychoticism, which is quirkiness. So we do have all of our flavors represented in these 5 trait domains, but no longer the 3. So yes, they are there and the flavors are there. We just organizing them closer to the data.
Okay, great. Well, thank you. That's bringing me up to speed. I guess the other thing I would say, the way I was trained to think of personality disorders is the consistent use of maladaptive or unhealthy or self-defeating coping mechanisms. You know, the healthier coping mechanisms kind of draw people to you and this kind of thing, and the unhealthy separate. Is that still part of this?
Absolutely. I do think that's actually a very nice way of, and destigmatizing way of thinking about personality disorder, because the patterns in self and interpersonal functioning that we adopt really stem from years and years of interaction. And I have to also, it's not that biology doesn't play a role. We do know from research that people come into the world with certain temperamental traits. They're biologically based. Some people are just more sensitive, more emotional. When I talk about this, I often challenge mental health professionals, because I always say that to become a mental health professional, you probably are more sensitive and emotionally reactive, because that allows you to have the kind of empathy that you need to be a good clinician. Now, that in itself is not pathological. So our traits don't determine whether we have personality disorder or not. But what happens if we're very sensitive, we evoke certain things from the environment. We may be evoking certain things from our parents. If our parents cannot slow down adequately, if they cannot match our temperament, we are going to get negative feedback. We're going to be invalidated about who we are. Someone's going to say, you're always so sensitive. Just pull up your socks and deal with it. If we have a parent who can slow down with us and try and validate, we are able to build a sense of self that is not incoherent, a sense of self that is positive, that can guide us through life. So we know from a lot of developmental research that personality disorder come about by the interaction of these sensitive traits with an environment that just cannot quite match it. We've stopped blaming parents, thank goodness. Parents are doing the best they can, but sometimes there is just a sensitive kiddo, and those the sensitivities cannot be met adequately. And over time, a sense of a self that is broken emerges, and people begin to engage in these coping mechanisms that you so nicely outlined that are just not helpful. That are just really perpetuating some of these negative views of self and other, rather than unlocking it. And that's what therapy then does. Therapy really says, we can do this differently. It's a malleable treatment target. You can manage yourself differently. You can manage relationships differently. Let's turn a new page and begin to do that.
Yeah. Yeah, unhealthy coping mechanisms become a self-fulfilling prophecy to some degree. But what I also like about coping mechanisms is they can be taught, they can be learned in a sense, right? So that's also a nice non-stigmatizing way of saying it. I mean, it's not bad or wrong what you're doing. It's just not getting you where you want to go. And here's a different way, maybe. Is that
spot on? Okay, I think this is a very helpful, and it empathizes with the fact that folks learned a way of coping with self and other that is not in their best interest.
Yeah. All right. Let's talk back to diagnosis. Obviously, there's a lot of misdiagnoses here, but there's also a lot of comorbidity. So what are the common misdiagnoses? And it's not always either or, I find. Sometimes it's both, right? So what would you say about that?
Well, thanks for bringing that up, because it's very complicated, because as you say, in some cases, there really is true co-occurrence of two disorders. So it's common that a person may have BPD or personality disorder and comorbid depression, because, over time, a person may become hopeless about ever finding a relationship that works or ever finding a job that's really satisfying for them. So, and anxiety. People with personality disorders are highly anxious. They're actually quite eager to please. They want to get on with people. They want to be connected to, they feel lonely easily. So, very anxious to please. So anxiety is a very common. Substance use, talking about maladaptive coping strategies, trying not to feel things by numbing it out with substances is very common. So it's true that we do find true co-occurrence of these disorders. I think where it gets misdiagnosed, bipolar disorder often. Yeah, common. So we see that so many times. Often bipolar 2 gets misdiagnosed. People really have BPD, but bipolar, and then they get medication, a mood stabilizer that just doesn't work, because this is not a disorder that lives in the mood system. It's a disorder that lives in self and interpersonal functioning. So it's often bipolarism. And what's recently been happening, very interestingly, is autism spectrum disorder. I think as we've opened up the autism diagnosis, when there are people who are struggling to get on with people and they can't read other people very well, and they struggle and they get upset when they can't read other people. Sometimes this is now also seen as autism spectrum, where, in my view, we could have diagnosed a personality disorder. So that's a common one. And then the third one, often in young people, is ADHD. Because of the impulsivity, sometimes people think this is all down to impulsivity. Actually, what gets missed there is that when people with personality disorder are impulsive, it's usually in the context of interpersonal relationships. So it is, trying to get a particular response from another person. That impulsive behavior is so it's different from what a person with ADHD really does, which is not necessarily always in interpersonal contexts.
Okay. Can you have borderline and autism or borderline and ADHD?
I think you can. So okay. I think you absolutely can. And again, I see a lot of youth. We run an adolescent clinic, and, often there is a pathway via externalizing behavior, so ADHD or conduct type problems, where a kid has high impulsivity. They're born with high impulsivity. And again, the parent or the context, including the school and society, are not matching the kid. And they start to give feedback that says you're a bad kid for not being able to sit still in your chair. That then can foster a personality disorder over time. So it's really important that we think about how to manage ADHD in a way that doesn't send messages that starts to affect development of self and development of identity.
Yeah. I would say, too, another very common comorbidity and a source of misdiagnosis that we didn't mention yet is PTSD. And it seems like, you tell me, but my understanding is the vast majority of people with borderline have had some significant trauma. Yeah.
This is another huge issue in the field right now. And of course, with the ICD-11 that came out in 2022, defining complex PTSD, which has a complex PTSD has this self component that regular PTSD, DSM-5 PTSD, doesn't really have. And so there's a lot of talk at the moment about complex PTSD versus BPD. And then, of course, always we've had PTSD in our mind when we were thinking about personality disorder. I think it's a complex conversation, and there's been meta-analytic studies now that have shown that there is a large proportion of people with personality disorder that did not experience trauma in a way that we typically assess for in PTSD. So in that sense, we look for objective signs of trauma. What most people with PD, though, will endorse is a subjective sense of trauma, feeling misunderstood, feeling victimized or bullied. Sometimes that maps onto what happened in the family environment. Sometimes it doesn't. When we work with people with personality disorder, we don't try and find the truth. The truth, we can never go back and turn back the clock to see what really happened, but the representation of that invalidation, the representation of the hurt is very real. And that's what we treat and what we work with.
Yeah. So it's sort of your perception is your reality to some degree.
Absolutely. Yeah. And it is real. It is the truth to the extent that to me, it feels like that. And this is how I've built my sense of self, is around this theme that I was mistreated. And therefore, it's a central part of the treatment to begin to say, okay, well, let's unpack that. Let's understand that. And let's see how we can move forward from that point.
Well, it's much in the same way I've conceptualized schizophrenia. The hallucinations and delusions are real to that person. You can't talk them out of that per se, you know? And so I find that really fascinating. Back to the PTSD for a quick second. Of course, people, particularly with borderline personality disorder, put themselves into situations, I guess, where they're likely to be abused as well. So there's that too.
That can happen. So with a higher level of trait impulsivity, and remember, a big part of the self-functioning in BPD is a sense of emptiness and a sense of, and that comes from, we conceptualize that it does come from a sort of invalidation, that there's not a trusting of the self, and that I can rely on myself and that I can tolerate myself. So there's often a seeking of external stimulation, and that's where substance use comes into play, or impulsive relationships, sometimes promiscuity. And of course, that may place a person in further danger, or you know, victimization roles. And so it is a very important part of the treatment as well, to start making different decisions.
Yeah, and of course, substance abuse puts you into bad situations and bad people sometimes too, I would say.
Sometimes it does. Yeah.
All right. If we could, before we get into treatment, if we could talk a little bit about neurobiology and genetics. I'm fascinated. What are the newer findings on the neurobiology here and the genetics that would be helpful to understand?
So from a genetic point of view, same heritability rates than all the other disorders. So we know that it's around 50%. It's around 50% for depression, for anxiety. I think schizophrenia, bipolar is a bit higher, but for personality disorder, around 50 to 55% heritability. And what is it that gets inherited? It's the traits. So it's that high level of impulsivity, emotional reactivity. But as we've said before, traits alone are not enough to diagnose personality disorder. It's what we do with our traits. And so the rest of the 50% that's environmentally determined is how we learn to deal with our traits. So if I'm going to build a picture of myself as a bad, impulsive person who makes poor decisions, that's going to lead me down a path of personality disorder versus, you know, I am impulsive, but I've learned to manage it. So traits in and of itself doesn't mean anything. But so when we look at the heritability, it's the traits, the temperament component of it that we inherit. But then there's this whole environmental piece that plays a large role in how we manage our traits. In terms of neurobiology, then there aren't real correlates that are specific to personality disorder. Areas where people have looked at sort of frontolimbic circuits, but we know that they're implicated in a lot of different disorders. There does seem to be in one meta-analytic study, an amygdala hypersensitivity. So, yes, there is an emotional sensitivity that we can see in brain function. But it's not specific to BPD, also not specifically treated in the sense that when we treat emotional dysregulation, a lot of positives come from that. It's not just the BPD traits that begin to respond to treatment of emotional dysregulation. We stop taking drugs when we treat emotion dysregulation and so forth. So no biological correlates that are really specific to BPD. I'm going to briefly go back to RDoC, Systems for Social Processes. I do think that in the last 10, 15 years, there's been a social neuroscience reawakening. I'm hopeful that in looking more at neurobiological correlates of cell function and attachment, that we may edge closer to something that's specific to personality functioning. But again, I think it's such a complex construct that it's unlikely that we'll find any specific genetic or neurobiological correlates for this problem.
Yeah, I certainly don't think any kind of neurobiologic visualization is going to help inform diagnosis. But if we could understand parts of the brain and, more importantly, circuitry, that might be informative for treatment planning, is what I'm thinking. Another question, though, about genetics is, my sense is that certain things do run in the families of bipolars. I always thought that mood disorders, substance abuse, things like that, perhaps bipolar, are those found more commonly in the families of people with borderline, or am I simplifying over some?
Yes, I think there is some data to say that there are higher levels of general psychopathology in people who have personality disorder. And again, I would look towards some of those trait vulnerabilities that place us at risk for a wide range of psychopathology. Impulsivity, emotional reactivity. Those are going to put you at risk for substance, for depression, for bipolar, for personality disorder.
That's helpful. All right, let's shift gears to the APA treatment guidelines that you were a part of. Are you able to, for our audience, to summarize these treatment guidelines a little bit, and then we can get into some specifics?
I think the main takeaways are that you, as a clinician, want to do a good assessment. You want to, there are some guidelines that are really asking you to slow down and get a really good picture of a person's personality functioning, of their history, because this is how you're going to distinguish between personality disorder and other comorbid disorders. So you really want to get a sense of a person's history in terms of their relationship lives, in terms of love and work, their self-directedness, were they able to sustain a job? What are the challenges in doing that? So you really want to zoom in on that self and interpersonal functioning. So a strong assessment phase that will also include risk for suicide and self-harm, and will also include risk for other risk-taking behaviors, because that's part of the picture. And one of your first goals is to keep your patients safe. And so I think that's a big guideline, is that there really needs to be a thorough assessment. I think a second big guideline is that psychopharmacology is going to be used for co-occurring disorders, but not for the personality disorder itself. So they're really trying to move away from trying to medicate the personality disorder, and being clear with the patient that, the core problem that you have is managing self in the context of interpersonal relationships. I don't have medication to treat that. We're going to have to do psychotherapy for that piece. But you've also become depressed because you're feeling hopeless, and I can give you an antidepressant to manage that. You've also become alcohol addicted to manage some of these negative feelings, and I can give you naltrexone for that. So just trying to be clear in the psychoeducation with the patient about what piece is being treated with medication and what piece is not being treated with a medication. So I think that's a second big guideline. And then the third one is psychotherapy. And we can delve a little bit more into what psychotherapy is about, but how do we also help our patients adhere to the treatment? And we can talk a little bit about that, because I think it's such a stigmatized disorder that it's hard to, I think there's a stance that clinicians can take that will improve adherence. And part of that stance is destigmatizing the disorder and not being afraid of it, taking it on, not referring out. We can talk about, what is that stance and how do we reduce clinician fear for a disorder that really just doesn't deserve the fear. So I think those are the main guidelines that we ended up trying to promote in this last set of guidelines.
Super helpful. And I like this idea as medication as an adjunct and not creating the expectation that medication will solve the problem. Could I ask a specific question about medication, though? I've heard naltrexone talked about to be used for impulsivity and self-injury. Is naltrexone helpful in self-injury in this context?
I think there is some evidence that it can, reduce some of the self-harm, but it's by no means a consistent finding or a finding that is, that it's just, the data just doesn't exist. So, for impulsivity, I think it can help a little bit. What you want to treat, though, is the core and the cause of why people self-harm. Not trying to put a Band-Aid on the symptom, but trying to really get at the cause of it.
Okay. Now, I definitely want to move into the psychotherapy, but you said something here that really clicked here. The person's core problem to some degree is interpersonal relationships, and now we're asking them to form an interpersonal relationship with a therapist.
Yes.
And that's going to be challenging because that's their that's their problem. So please elaborate more on what you said earlier about how we can conceptualize and create the environment and this kind of thing.
Thank you so much, because this is the core of what we need to talk about. Thank you. I think if we start out with the stigma associated with this, we know from research that the stigma is most prevalent among mental health professionals. So the idea that there's a couple of myths. The fact that it's an untreatable disorder. The fact that, everybody with BPD looks like Glenn Close in Fatal Attraction,
Right.
So it's a spectrum disorder, and there are a lot of manifestations of BPD that most of it is very low down on the severity spectrum and not the very severe. But it is true that it is at its core an interpersonal disorder. So it's very important that the clinician has a stance that is transparent and one that opens up the door for trust. If we think about BPD, at its core, it's a disorder that comes out of a severe mistrust of other people's intentions, a severe mistrust that other people are acting in the best interest of myself. And it comes out of a perceived invalidation that has gone on for many, many years. So it's very important, I think, and I think one of the big gifts that Marsha Linehan gave us with DBT, and Peter Fonagy and Anthony Bateman with Mentalization-based therapy, was to teach us as clinicians to be transparent, to put our minds on the table. Not, the idea of the psychoanalytic couch was the most iatrogenic thing that you could do with a person with BPD. What a person with BPD wants is for you to connect with them human to human, in an open, transparent way. So if you are worried about them, say so. Say, I'm worried about keeping you safe. Can we talk about how we're going to, how can I leave today's session knowing that I'm going to see you next week? Let's come up with a safety plan. So that open, transparent, putting your mind on the table is what we call it in mentalization-based therapy. Saying what you mean and meaning what you say, because people with BPD have an inauthenticity detector. And if you're in a professional role or in a role of authority, you lose them. So it's really getting onto the same level and connecting as a human to human. And when you are confused about what they're saying or doing, say so. Say, I'm not quite following. Are you saying that this? Are you saying that? Can I clarify? I want to understand you. In that attempt to show that you want to understand, you build trust. And that's that trust that will help the patient come back and adhere to the treatment that you are trying to do. So you're absolutely right that and there are books written that people can go and read if they're interested in how to embody this stance. We call it a mentalizing stance, a stance that says, I am not making assumptions about who you are. I'm not making assumptions about that, based on your diagnosis, that this is going to be a difficult relationship. I'm completely open to go with you where this relationship takes me. But what I am interested in is getting to know you and understanding you and putting together the complexity of who you are. And when you communicate that as a clinician, a person with BPD will trust you and they will not feel invalidated by being labeled as a difficult, mean, untreatable person. That's the challenge. That's the first sort of nut that you need to crack when you start working with someone with BPD.
So how much of this is modeling a healthier relationship? Is there some of that to it?
Yes.
Okay.
Absolutely. It is modeling a relationship where I'm going to slow down to really try and understand you without jumping to conclusions, without taking shortcuts, without assuming things about who you are. And that's the main treatment modality, yes.
Well, let's get into then the two structured psychotherapies that you mentioned. I'm a little more familiar with DBT and Marsha Linehan than I am MBT. So maybe you could outline the two and then maybe the differences and how people could, most importantly, how people could learn more about them.
So I think they are both wonderful treatments. There's a third evidence-based treatment, actually four, that also have some RCTs behind them, transference focused therapy, and then schema therapy has some RCTs. There's also a couple of trials for STEPS. STEPS is a sort of DBT light that you can do in groups. But let me talk about the two big ones, DBT and MBT. Dialectical behavior therapy is really a genius therapy that Marsha Linehan developed, trying to communicate at the same time two things. That's why it's called dialectic. It is communicating acceptance and change. And again, this is so important for people with personality disorder because they've been invalidated so often that change alone would not land. So, but acceptance and change together land. So I'm accepting who you are. We're accepting this relationship. I'm accepting my past. And at the same time, I can bring some changes for a new life, for, in Marsha Linehan's terms, a life worth living. So that's such a beautiful concept. John Gunderson, of course, big BPD researcher and thinker, he talked also about getting a life. Back to Freud's love and work. It really is always on the focus is always on functioning. How can I have a life worth living? How can I get a life back? So that's DBT. And of course, it focuses on emotion dysregulation as a core feature of what derails love and work. But I love the dialectic. I love the idea that the person is validated and at the same time is challenged to do something different. MBT, which is my main modality, is really focused on the idea that people with BPD feel misunderstood and have been feeling misunderstood for a very long time. And that as a result, what happens in relationships is that they end up misunderstanding other people as well. So we have two people interacting with each other and both are misunderstanding each other. Both are taking shortcuts. Both are making assumptions about what's in the other person's mind, and it blows up really, really quickly. What do we do in MBT? We slow down and we say we're not going to make assumptions about what's in your mind. I'm going to clarify. If this doesn't make sense to me, I'm going to say, hang on, I'm not getting what you're saying right now. Can we just rewind so that how do you move from X to Y? Walk me through that so that I can get a better understanding. So if I take, for instance, I work a lot with young people. If I have a young people that says, my mom, she just wants me to do what she wants. This makes me crazy. I'm just going to run away. I'm going to say, well, hang on. Can you tell me exactly what it is? Put it in a movie for me so that I can see what is it exactly that your mom is doing that makes you feel that she's not understanding you. I can guess and I can imagine because mom has spoken to me, but I'm not going to jump to that because what's in the teenager's mind in front of me is very unique. It's like a fingerprint. It's her unique fingerprint. It's her unique interpretation. So I'm going to slow down and I'm going to say, walk me through it. In doing that, I am making that young person feel understood and she is able to trust me. And can we say, okay, how can we do this differently? So we're back to change and acceptance, but just through a different mechanism than in DBT.
Boy, those two core things are so helpful, the acceptance and change. And the change, of course, comes about from saying, look, what you've been doing isn't getting you where you want to go, essentially.
Right.
And maybe we can back up and try something different, I guess, right?
Because this is perhaps useful for clinicians. People with personality disorder are profoundly alone. They are profoundly alone. And if you can tap into understanding that and having empathy with that, you will be able to help them change because they want, like all of us, connection with other people. So there's a nice book written about how do you hug a cactus, and it's really for teenagers. But people with BPD can be the same. They can be like a cactus, and our challenge is to break through those tentacles and because they have the same human needs than everybody else.
It's so funny you use the cactus. One of my professors, when I was in training, used the porcupine analogy and said they're like porcupines that want to hug somebody.
Yes.
So that's a very good analogy. All right. Tell me a little bit about DBT and MBT. How long a period of treatment are we talking about? How long?
That's another very important question in the field right now. The traditional classic RCT evidence is based on 1 to 2 years of therapy. What we've learned, though, is that everybody doesn't need that. So because we now have a better understanding of the psychopathology lying on a continuum, we know that there are people at the severe end that may need this full dosage. There are, however, people at lower levels of the severity continuum who don't need that. So what everybody's doing right now is figuring out dosage. Figuring out, is 6 months enough? There's no clear answer right now. I think we're getting better at calibrating this. But the classic DBT and MBT is really viewed as 1 to 2 years of work that you do. Yeah.
And of course, once you've completed that, let's say a person is, in what you might call remission or significantly improved, do you then have to have a period later of retreating or, I would imagine it doesn't always hold a charge, is what I'm saying.
Oh, you're absolutely right. Like any psychiatric disorder, depression is the same. We carry it in our bodies. BPD is the same thing. We always, if you have BPD, Kernberg's concept of borderline organization is so helpful in that regard because it means what Kernberg meant with that was that your personality structure is organized at that level. So you're always going to be vulnerable. It's like the scaffolding that your house is built on. It looks like that. And so, yes, you learn ways of tweaking it and you learn ways of managing it, like depression, substance use is the same. But you're always vulnerable and you need to know what your triggers are. So perhaps you do lose the love of your life. After a 15-year relationship, you're someone with a borderline organization structure and suddenly you feel extremely vulnerable again. Suddenly you feel extremely vulnerable to abandonment again and you have to find a new footing in life. And you may have a relapse in terms of those very kind of paranoid ideations that people with BPD have. You may have a relapse of feeling unstable in your sense of self and feeling lost and empty and alone again. And then you will need treatment again. But if you had a good therapist, then you will be able to dig back into that toolbox. Or you can, re-enter therapy. So I absolutely think like any psychiatric disorder, it's something that you revisit through your life if you're someone with BPD, but you get better at it every time, and you get better at managing it, and with the right help, build a toolbox that could be sustainable.
I like this idea of vulnerability, because we all have different vulnerabilities, of course. And the notion that you can't go through life and not have loss and stress and things that are going to bring some of this out.
Yeah, I think knowing your triggers and knowing what makes you vulnerable to have a self and interpersonal relapse, that's the key.
Well, and of course, if you've had a good relationship with a therapist, you're more likely to go back to them and be able to trust and reinitiate, I guess is what you'd said, or
absolutely
back into therapy. And then I would imagine that second course might not have to be as long.
Absolutely.
It's sort of a topping off of the gas tank or something.
Wouldn't have to be so long. And the other principle that I think that has emerged over the last 10 years is that therapy should be time limited. This idea that a person with personality disorder should be in therapy all their life, then they're not getting the right therapy. Therapy should be time limited. There should be goals. People should be getting better because people do get better. But after time limit, we terminate therapy, and we can have booster sessions every 6 months, or if you have a relapse, come back. But I think that we are trying to move away from this notion that people with personality disorders should be in therapy all the time. What we want to do is we want to activate the social network, the natural salutogenic power that lies in we want to give people the skills to make use of relationships in their regular life, not the relationship with a therapist, to move forward long term.
Yeah, we don't want to encourage dependence on the therapist or the therapy, I guess, right?
Exactly.
There's that terrible old hackneyed saying, you don't want to give a person a fish, you want to teach them how to fish.
That's exactly right.
Terrible saying, but it does fit.
Yes.
All right. Well, with the time we have left, a couple of other quick questions, and I can't believe how fast our time has gone here, Carla. I've learned so much, and I hope our audience has gotten something out of it. But what does the research say about long-term outcomes? I mean, you've already told me, I guess one of the misconceptions is these people can't get better, but what is the long-term outcomes? And are there certain factors that do predict remission or improvement?
Yeah. So we don't have a ton of data, but the data that we do have on like 20-year follow-up type outcomes show that there is remission. Most people with BPD get better in terms of their symptoms. They don't meet criteria. They are truly in remission. What doesn't respond as well to treatment and is currently another focus of research and treatment development is functional impairment. So people are not quite yet having a life worth living. Their lives get manageable. Impulsivity reduces. Self-harm, suicide reduces. But thriving is not always achieved. And so I think that's something we're trying to figure out as a field. How can we get there? We do know one of the moderators of getting to thriving is early intervention. The sooner we can diagnose, the sooner we can begin to treat, the better the outcomes are. So we want to really shift the focus to early intervention, and then I think some of the other moderators are physical illness. We know that folks with physical problems, because there's a huge comorbidity actually of physical problems as well with people with personality disorder, obesity.
Yes, cardiovascular disease, diabetes. Yeah,
yes.
We have those same associations with many of our disorders, bipolar, depression, and schizophrenia, and so on. Yeah.
So that all of those will improve functional recovery and so forth. But early intervention, we've all become quite big advocates for early intervention and prevention to some degree.
Boy, that's really helpful. We talked about some of the barriers here. Of course, some of the barriers are having an experienced, skilled therapist, and they're not a dime a dozen, obviously, and someone who's been trained in one of these techniques. But, and then there's the barrier of our own stigmatization, our fear. I think you said that well. I think we use the term borderline very pejoratively, and we're afraid of these patients to some degree. Are there other barriers that we haven't talked about, and maybe how we can help overcome those?
I think if I, have one that I want to put out there, it is the idea that only specialized treatment works. And so, if we think about the classic 1 to 2 years DBT and MBT and what happens with clinicians, they want to be ethical practitioners. So when they get a person with BPD coming into their practice, they refer and they're trying to find DBT, MBT centers, and they try and refer out. Where we are now, and this is thanks to John Gunderson and Lois Choi Kane, is that we do know that general psychiatric management also works. And so I would encourage the audience to go and find any book on general psychiatric management, GPM, and just read the principles of general psychiatric management for BPD. There are some general things that the frontline clinician can do to manage the disorder in their regular clinical practice. Yes, you can still try and find them a place at a DBT center or an MBT center where they can get specialized treatment. But the frontline regular psychiatrists and clinical psychologists can be of help. And so I think that getting past this barrier of it has to be specialized treatment is another important advance that the field is at the cusp of.
Very helpful. There's one question I forgot to ask. I should have asked this at the beginning. It's a silly one, a basic one, I should say, not silly, but how common is borderline personality disorder?
It was actually in my mind early on when we just started talking, but generally speaking, 1 to 3% for BPD. However, when we start looking at any personality disorder, and if we take the AMPD and we say we're just talking about maladaptive self-interpersonal functioning, it really gets up to about 7% of the population, in general population, would have a personality disorder. But for BPD specifically, the data is between 1 and 3%. So again, thinking about it dimensionally, I think all of us can work on our personality functioning. I think it'll make for a better society. And so nothing stops us from enhancing our mentalizing skills, enhancing our emotion regulation skills if we think DBT. So I'm really challenging everybody who's been listening to think dimensionally, think about early intervention, thinking about intervening, not only for when it reaches clinical threshold, but before. I think there's a lot of mileage in taking this dimensional approach where we are just opening ourselves up a bit more for personality functioning writ large, and not the category of BPD.
Well, you just anticipated my final question, which was final words. Could you summarize? You did it beautifully. I guess I have one last question is, if people wanted to learn more, certainly they could look at the APA guidelines. Are there any other resources where someone could learn more?
I think a very nice book just came out recently that Joel Paris wrote. He's been in the field for a long time. He's written a really accessible guide for BPD that's just come out. I would also encourage either John Gunderson or Lois Choi Kane's General Psychiatric Management books, because again, it gives a frontline clinician the accessible guidelines that they need to hit the ground running today without having to go and do excessive and expensive treatment modality training.
That's very helpful. And you can obviously, there's plenty of information out there about DBT, which is Dialectical Behavior Therapy, and MBT, Mentalization-based Therapy. Well, Carla, this has just been tremendous. I thank you so much. I feel like I should get CME credit just from talking to you because you've updated my knowledge base tremendously.
That's so kind. Thank you. I'm just glad that you're shining a light on this disorder that we don't speak about too often. So thank you very much to you, Andy.
Thank you. And I want to also tell the audience that for more information about our other educational offerings, including podcasts, live meetings, virtual meetings, and other resources, please go to our website, which is NEIglobal.com. Carla, thanks again so much.
Thank you, Andy. Take care.
All right, take care.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.